Okay, so let's move toward pharmacology and pharmacodynamics. Now, our local anesthetic consists of a lipid-soluble aromatic benzene ring connected to an amide group via either an amide or an ester moiety. Now, this linkage basically categorizes the local anesthetic into amino esters or aminoamides, esters or amide. It also determines how they're metabolized. Esters are hydrolyzed by plasma cholinesterases, and aminoamides are degraded by hepatic carboxylesterases or cytochrome P450s. Some metabolites of the amino esters, like para-aminobenzoic acid, PABA, can induce immunologic reactions and are responsible for the slightly greater incidence of the allergic reaction associated with the esters. Other than these characteristics, physiochemical properties of both amino esters and amides are very similar and are really determined by their dissociative constant, lipophilic makeup, and spatial arrangement of their molecules. The tertiary amide, a local anesthetic, can accept a proton at low affinity, so these compounds are classified as weak bases. That's why they're weak bases. In aqueous solution, local anesthetics are in constant equilibrium between the protonated cationic form and the lipid-soluble neutral form. The ratio of the two forms depends on the pKa, or the dissociation constant of the local anesthetics, and the surrounding pH. A ratio with high concentration of the lipid-soluble form favors intracellular entry because it's not charged, since the charged form cannot go through the membrane. Clinically, the proportion of the lipid-soluble form can be increased by alkalization of the local anesthetic, and this can improve the onset of action. But once inside the cell, equilibrium is reestablished between the cationic and the neutral forms, and the charged form can bind and block the sodium channels. By far, the most important physiochemical property of these local anesthetic is their lipid solubility or lipophilicity. Lipid solubility of the local anesthetic is really determined by the composition of their alkyl substitute on the amide and benzene group that you can see here in red right here. That determines the lipophilicity. Now, in the laboratory, this lipid solubility is measured by the partition coefficient in a hydrophobic solvent, and typically they use octanol. And compounds with high octanol buffer partition coefficient are really more lipid soluble. Potency of the local anesthetics and their octanol buffer partition coefficient are correlated. So it's safe to say that highly lipid soluble agents are more potent and tend to have a longer duration of action than the ones that are less lipid soluble. The lipophilic property of the local anesthetics may act at two levels, though. The first is at the level of cellular entry, as greater lipid solubility facilitates passage through the lipid membrane barrier because the charged form can't go through the membrane. The second is at the level of binding to the sodium channels, though. In reality, many other factors influence the potency of local anesthetics. It's not just the lipid solubility. These highly lipid-soluble agents may be sequestered into surrounding adipose tissue cells and myelin sheaths. Local anesthetic causes vasodilation, which in turn could alter regional drug distribution. Finally, some local anesthetic can enter certain neurons via some non-specific cation channels and entirely bypass the lipid bilayer because they go through a channel. So clinically, we use relative potency of local anesthetics. Now remember that anesthetic activity and potency are affected by the stereochemistry of the local anesthetic molecules. Many older drugs perhaps kind of existed as a racemic mixture, that's enantiomeric stereoisomers in equal proportions. Newer agents like ropivacaine is available as specific enantiomer, which is at the expense of a slightly decrease in potency overall and shorter duration of action compared to the racemic mixture. Now, this is just a table of the physicochemical properties of the local anesthetics. Here you can compare the pKa and how it correlates with the person ionization at the physiologic pH. Also, you can see the partition coefficient and protein binding. So, here you can see the pKa. Look at the ones that have the highest pKa. Look at procaine, chloroprocaine, compare the ones with lower pKa's, like lidocaine, etidocaine, etc. And again, these pKa and percent ionization are directly correlated. And again, you can look at the protein binding. Note that for chloroprocaine, it's irrelevant because it doesn't bind to any protein. And here you can see etidocaine. Bupivacaine is 95% protein bound, and also procaine is only 6%. So remember these differences, like the ones that are at the extreme, for especially board reasons. Now, there are many things we can add to the local anesthetics, but these are the most common ones. So with epinephrine, adding epi to local anesthetic prolongs the duration of the block, increases the intensity of the block, and decreases systemic absorption of the local anesthetic. Now, epi's vasoconstrictive effect augment local anesthetics by antagonizing really their inherent vasodilating effects of the local anesthetics. So it decreases the systemic absorption and intraneural clearance, and maybe by redistributing intraneural local anesthetics. Now, direct analgesic effect from epinephrine can also occur because of the interaction with the alpha-teradrenergic receptor in the brain and spinal cord, especially because the local anesthetic increases the vascular uptake of epinephrine. But remember that the smallest dose should be used because epi combined with the local anesthetic can have toxic effect on the tissue, the cardiovascular system, peripheral nerves, and the spinal cord itself. What about the alkalization of the local anesthetic? Now, local anesthetic solution, as you know, are alkalized to improve the onset of neural block. Now, the pH of the commercial preparation of the local anesthetic ranges from 3.9 to 6.5, and is especially acidic if prepackaged with epinephrine. So this acidity is particularly good because it increases the shelf life. Now, because of the pKa of the commonly used local anesthetic ranges from 7.6 to 8.9, about 3% of these local anesthetic molecules exist as lipid-soluble neutral form. They're pretty much all charged. So when we alkalize it, it increases the ratio of the non-ionized or uncharged form. Now, so why can't we just keep adding bicarb to it to bring the pH higher? Well, the problem is our local anesthetic can't be alkalized beyond the pH of 6.05 to 8 before precipitation occurs, and these pH values will only increase the neutral form to about 10%, which may really clinically mean 5 minutes of improved onset, but may also actually reduce the duration of action. Now, interestingly, chloroprocaine is the most sensitive one with alkalization. So if you try to alkalize chloroprocaine, even with a little bit of bicarb, it can precipitate immediately. Now, what about opioids? As you know, opioids have multiple central and peripheral mechanisms of analgesic action. Spinal opioids provide analgesia primarily by attenuating the C fiber nociception, and this is independent of the supraspinal mechanisms. When we co-administer the opioid with the central neuraxial local anesthetic, we get a synergistic analgesia. But remember, there is an exception to this. That is the exception of chloroprocaine. And with chloroprocaine, we get decreasing the effectiveness of the opioid when it's given with it. We're not really sure how, but we know that it's not direct antagonism. So giving opioids in joints, peripheral nerves, is not really supported by clinical evidence either. What about clonidine, dexmedetomidine, the alpha-2 agonist? Now, these agents can be useful adjuvant to local anesthetics because of their direct inhibitory effect on the peripheral conductions on the A and C fibers. So, additional clonidine may have multiple mechanisms of action depending on the type of application. Co-administration of these alpha-2 agents on local anesthetic results in central neuraxial and peripheral analgesic synergy, while systemic or supraspinal effects are also additive. So on average, clonidine improves the duration of analgesia by about 2 hours, regardless of whether an intermediate or long-acting local anesthetic is used. There's also evidence to support the use of clonidine in peripheral, spinal, and epidural analgesia. What about steroids? We use potent glucocorticoid injection for chronic low back pain with good evidence. Addition of dexamethasone to a mixture of local anesthetic prolongs the conduction block after peripheral nerve application. Interestingly, the duration of the blockade is associated with the potency of the glucocorticoid activity and appears to be specific steroid receptor dependent and locally mediated, not central. Use or systemic. Use of decadron as an adjuvant to local anesthetic actually increases the duration in peripheral and intravenous regional anesthesia. So technically you may be able to use it in beer blocks. What about liposomes? Now, we have commercially available prep of liposomal bupivacaine, and they're designed to provide sustained release of encapsulated bupivacaine after a single administration. Now, despite the increase in cost, they do tend to increase the duration of the block. But the question that we have to answer is the increase in duration justified by the increase in cost? As you can see in this table, epi has a varying effect on duration of local anesthetic. Now, a simple rule of thumb is if the local anesthetic is vasodilating like lidocaine, epi improves the duration. If the local anesthetic is not vasodilating like bupivacaine, epi has little effect here. So here you can see bupivacaine, when we add epi to it, maybe a little bit improvement. Lidocaine, a lot. Bupivacaine, a lot. Ropivacaine, similar to bupivacaine. Again, similar to epidural here, same thing with spinal, and again, the drug itself is vasodilating versus vasoconstricting. Does that make a difference? Yes, it does. Now let's move to the pharmacokinetics of the local anesthetic. The plasma concentration of the local anesthetic is really a function of the dose given and the rate of systemic absorption, tissue distribution, and the drug elimination. Elevated levels may produce unintended effects in other electric sensitive systems, like the cardiovascular system, like the brain. You need to be extremely knowledgeable in understanding of the factors involved to maximize the local anesthetic potential while avoiding the possible complications. Now, decreasing systemic absorption of local anesthetics increases their safety margin in clinical use. The rate and extent of systemic absorption depend on the site of injection, the dose, the drug, the intrinsic drug pharmacokinetic properties, and the addition of any vasoactive agents. The vascularity of the tissue also influences the rate of drug absorption. So injecting in a vessel-rich tissue results in a higher peak plasma level in a shorter period of time. So the rate of systemic absorption is greatest with intercostal nerve block, followed by caudal, epidural, brachial plexus, femoral, and finally sciatic nerve blocks. So the same amount of local anesthetics injected would result in unequal peak plasma level depending on where you inject it. For a given site of injection, the rate of systemic absorption and the peak plasma level are directly proportional to the dose of local anesthetic. This relationship is almost linear and independent of the drug concentration and the speed of injection. The rate of systemic absorption is different between individual local anesthetics, as you can imagine. In general, the more potent lipid-soluble agents are associated with a slower rate of absorption than the less lipid-soluble agents. Also remember that the local anesthetics exert direct effect on vascular smooth muscle in a concentration-dependent manner. Interestingly, at low concentration, more potent agents cause more vasoconstriction than the less potent agent, so we get lower vascular absorption. But at high concentration, vasodilatory effect seems to take over for most local anesthetics. Here you can see the Cmax and the Tmax of injection of specific doses of local anesthetic at specific sites. So here you can look at the bupivacaine, 150 milligram given, You can see the average Tmax, the time it gets to get the maximum plasma concentration. 20 minutes, 17, 20, 30, 24, less than 30 minutes. Now here, if you give 400 milligram in femoral or sciatic, you get 15 minutes for Tmax, but that's kind of a little bit on the high side. But again, that's the Tmax, that's the time it takes for you to get the maximum plasma concentration. And it's fairly in the same range for most of the local anesthetic we tend to use. Same with lidocaine. Bupivacaine is a little bit shorter. You can see here, ropivacaine is also a little bit longer than bupivacaine. But these are I'm not very happy with the studies that were looked at for ropivacaine here. So if you are redosing your local anesthetic 2 to 3 hours, let's say 3 hours, after you already gave, let's say, 2.5 milligram per kilogram of bupivacaine. It's been 3 hours. Can you redose it? And how do you determine that? This is something we should talk about during the class. Now, systemic absorption of local anesthetic leads to rapid distribution throughout the body. The steady state drug concentration in plasma can be derived from the apparent volume of distribution. But regional differences in local anesthetic concentrations are seen among individual organ systems. The pattern of distribution is largely dependent on organ perfusion, the partition coefficient between compartments, and plasma protein binding. Organs that are well perfused, like the heart and the brain, get higher drug concentration. So they're also the organs most seriously affected by local anesthetic toxicity. The metabolic pathway for clearance of local anesthetic is primarily determined by their chemical linkage. The esters are hydrolyzed by plasmacolonesterases. The amides are transformed by hepatic carboxyl esterases and cytochrome P450. Now, severe liver disease may slow the clearance of aminoamide local anesthetic, and significant drug level may therefore accumulate. The primary benefit of understanding the systemic pharmacokinetic of local anesthetic is the ability to predict the peak plasma levels, or the Cmax, after you inject local anesthetic, so we can avoid toxic doses. The problem is pharmacokinetics are difficult to predict in any given circumstance, because both physical and pathophysiologic characteristics will affect the individual pharmacokinetics. There is evidence for increased systemic plasma levels of the local anesthetics in the very young and in the elderly because of decreased clearance and increased absorption. Interestingly, the correlation of systemic blood levels between the dose of local anesthetic and weight is often inconsistent. Effects of gender on clinical pharmacokinetics of local anesthetics have not really been defined, but what we know is pregnancy decreases the clearance of local anesthetics. Pathophysiologic states like cardiac and hepatic disease will alter expected pharmacokinetic parameters, and lower doses of the local anesthetic should be used in these patients. And as you can imagine, renal disease has little effect on the pharmacokinetic of the local anesthetics. All of these factors should be considered when using local anesthetic, so that we can minimize systemic toxicity. Now here, take a look at the toxicity potential of lidocaine with bupivacaine and chloroprocaine. So if lidocaine, the relative toxicity for CNS is 1, you can see bupivacaine is 4. Now, moving toward other agents, you can see where is chloroprocaine. Chloroprocaine is 0.3%, and ropivacaine is pretty close to the bupivacaine here. And here you can see the relative cardiovascular over CNS. So bupivacaine is again 2, and let's go back to lidocaine, 7.1. Effect of, here you can see the effect, the differences in clearance with specific organ pathology. So here in a normal person, you can see the clearance of the local anesthetic is 10, half-life is 1.8 hours, so 2 hours. Cardiac failure, similar. Hepatic disease, half-life goes up. Renal disease, half-life goes down. But again, look at the clearances. Normal is 10,
clearance goes down with cardiac and hepatic disease, and essentially unchanged clearance with renal.